When I was talking about the show, I thought to myself, this would be a really great resource for new parents and new mothers that are in the position that I'm in, that have questions, that don't know what to ask. And this was going to be a way for me to kind of find out what those questions were for myself.
My background is in human and organizational systems and human development. And just based on my own birth experiences, which were a number of years ago, I've come to the conclusion that people want to make their own choices, but they want to make informed choices. So what we're aiming to do with this TV series is to present information, to bring in subject matter experts, to talk to parents, and explore the kaleidoscope of choices that are available to new parents.
I live in Drayton Valley, Alberta, which is about an hour and a half from door to door from the Lucina Centre. I'm coming to Edmonton because you can't actually deliver babies at the hospital in Drayton Valley. So there's one reason. And another reason, the biggest reason, is because I've wanted midwife care. I think it was probably in the last 2 years or so that they don't deliver babies unless, I guess, it's an emergency and the baby's coming out. I've had fairly fast deliveries. Hopefully it's not a highway baby.
In Canada, we have the privilege of universal health care, but not every pregnant person has equitable access to care. People living in rural, remote, and Indigenous communities may not even have maternity care locally, and there may be limited access for other marginalized people, such as adolescents, LGBTQ people, and people with health challenges. In this episode, we speak primarily with professionals who are familiar with the challenges of underserved people. We talk to physicians, midwives, a nurse practitioner, doula, and social worker. We'll start by hearing from physician Andre and doula Claire about making maternity care more accessible.
Access to maternity care has become a range of disparity between different sections of the population.
We don't want to just think of urban, middle-class white women. We want to think of everyone, and we want to give them opportunities to have a satisfying birth.
Equity is on the downturn for rural and marginalized communities, even in cities.
For vulnerable populations, it's even more important because there's a big cost to society to when their children are not born healthy, or when their children don't receive prenatal support, when the women don't receive prenatal support. We know the research shows that there's a long-term effects over society.
If you're not in a centralized area, you're more remote, you're rural, you're a marginalized community, you're an immigration community, your access is not the same.
And that is exacerbated for vulnerable populations, such as Aboriginal women, women of low incomes, single women, but also to a certain extent, women in rural areas or women in remote areas.
The more further you are from a center, the more you will not having access to the same level of care. With the advent of centralizing care and in the process to try to save costs though, which works for certain advanced diseases and elder care, etc., when we centralize it, we tend to forget the fact that obstetrical care doesn't follow those rules.
So for example, if we had more access to maternity care, to prenatal care, to more professionals offering options in childbirth, we know that that would lower a lot of costs.
Rural communities need equitable health care, and to provide equity, you might need to provide more services, maybe at a different funding model to sustain rural health care.
So if we invest in maternity care, we know that it would lower the cost of society.
In this segment, rural midwives and physicians as well as an urban-based obstetrician and midwife, talk about their ideas for increasing access in rural and remote areas.
I believe that women can give birth rurally, who are low risk, who are suitable for the community setting and not need access to an OR. But ideally, if there was that access, it certainly is a comfort to the practitioner and a comfort to the families as well.
If you put it down on a paper and look at how certain communities can collaborate their resources, make it financially sustainable, use all the providers in that area, increase the number of patients, and also make it then more accessible for specialty care and further support.
If there's a community, there is no obstetrician willing to go there, or that community does not have a population large enough to support an obstetrician being there, because obviously if I'm an obstetrician, I need to have a significant amount of a significant amount of patients that I can take care of. Otherwise, I would have a practice, I'll be doing one delivery a month, and that does not allow me to have a practice. So certainly in those situations, the best what we can do is have a physician who has advanced surgical skills.
Those advanced skills is defined by more intervention than just a regular normal vaginal delivery.
If that's the only physician that's available, that's the only physician that's available. So they'll have to make do with that. And I'm actually quite grateful that there are physicians out there who are providing these services to these women who otherwise would not have access to care.
The key to working well in a rural community is becoming integrated in a care team.
The advance about that is more the intervention like spinal anesthetics and general anesthetics and in epidural anesthetics. So that's the advanced skills that a general practitioner can ascertain to provide care.
In an ideal world, we would have a system that allowed a GP anesthetist or a GP surgeon to maintain a practice rurally that would sustain their families.
So you could run the public health, the midwifery clinics through this one building. You could rent out spaces to local health practitioners like herbalists, acupuncturists, massage therapists, even physicians, and start to get some more work across the different health professionals, the nurses, doctors, and physicians and midwives. That would be really amazing if something like that happened.
So we work very closely with the family physicians in our medical clinic, with our nurse practitioner, with the public health nurses. We really see ourselves as totally integrated into our hospital setting here. We do offer home birth as well, but we don't work in isolation.
I think there's some opportunities in a small area in that all the people on the team rely on each other all the time and for things outside of obstetrics.
Have we had hiccups? Yeah, because they have been challenges, but the one thing with the family docs that I work with down in High River, they trust birth. They wouldn't be down here doing obstetrics if they didn't trust birth to be a normal life event.
So you can't do anything like this in isolation. It's about a community, seeing a need, and then having a few key people who've had that vision but never know how to do it, and it comes together.
That creates that ability for us to improve access and also improve teamwork and improve mutual respect for different roles. To summarize that, physicians and midwives working together provides a significantly better obstetrical experience for any mother.
Now we're going to consider the role that midwives can play in rural communities and the collaboration that can take place in low-risk settings with other healthcare professionals, such as physicians and nurse practitioners.
For many rural communities, sustaining obstetrics is a high priority. And so I see midwives as a real key to that. But I also see family physicians who are willing to work alongside midwives and support them.
I would really like to see midwives working in rural settings. I think that they would offer a whole range of resources, not only to mothers and babies, but also to the physicians, to the public health nurses.
I would say if someone's got a vision for working in a rural community and a rural community wants midwifery, they need to not just find a midwife, but they have to find at least one or two champions in their medical community to come alongside and partner.
We have perhaps a unique ability within the healthcare system to be comfortable outside of a highly mechanized hospital. When we're talking about rural families and the travel some of them have to do to get to one of these hospitals, I would hope that we would be able to set up lots of satellite midwifery clinics.
One midwife can't give care in isolation, and particularly in rural. In the city it's a little different. You have 5 or 6 hospitals, you hit a button, everybody shows up. In rural practice, you have to be part of a team.
Midwifery care is a 24/7 job, and so if there aren't sufficient midwives in the community to cover those needs, a midwife can get burned out quite easily because she's not able to take time off or leave her community. So it's really important to build a sustainable network for midwives in the rural communities that they work in.
Well, I think that the people involved have to want it.
To bring a midwife into a community that's never had a midwife before is really it's a little bit of a challenge, because you can't just pick a midwife up and plonk her into a community. There has to be some relationship building, some respect of each other's scope of practice and of each other's role.
There were some challenges of integrating midwives into our group. There were hardly any from a patient perspective, which was interesting, because I thought that would be the big problem, particularly because our first midwife also worked as a nurse at the hospital at the same time. And so one day she might be the nurse, the next day she's delivering their baby, which I thought would really send patients like for a loop, but they didn't even blink, they got it, it was a non-issue, right? So that's what I thought was going to be the big issue, and there was absolutely none from the patient perspective. There didn't seem to be much on the unit with the nurses and the administration of the hospital, probably because our midwife was a known entity. Everybody knew her, we knew her skills, we knew her knowledge base, everybody trusted her.
Initially when I came, there was a lot of education to be done, exactly what can you do, what can you not do, this is what we can offer, can you offer.
Our model is great, it works really well for us, but I'm not sure you could just pick it up and plunk it down somewhere else with people who don't know each other already. There were and are some ongoing challenges, just in a bit of different philosophy, but I think that it has been beneficial for both groups.
My vision would be that I would see them being able to work like in a low-risk prenatal clinic with the physicians, that we would see each other's patients, and that in some ways we'd be kind of interchangeable.
It needs to be a ground-up kind of thing. There needs to be a will for this kind of model on both the physicians and the midwife's part, because there's going to be some, I don't know if compromise is the right word, but there's going to be some things along the way that you have to deal with. And unless there's a commitment to make the model work to begin with and a desire to make it work, there's 100 reasons for it not to work.
It might be a bit tricky with home births, because I don't know that many doctors are going out and doing home births just yet, but you never know. Those kinds of things may evolve with time, and as we work together and everybody realizes, you know, that this isn't a scary thing and we could do this too. But I really would see it as a team.
It's got to be that right relationship, and I think a respectful relationship, and just an understanding that we all want the same thing, a safe mum, safe baby, the best experience we can make it be, but it's about safety ultimately.
There's lots of rural communities in Alberta who need midwives and who would welcome midwives, and if those midwives are able to envision working in a collaborative care team, they will be successful.
In this segment, you find out more about nurse practitioners and hear from a midwife and physician about some of the challenges faced by marginalized populations.
Women deserve to have choice in who provides their health care, whether it's a nurse practitioner, whether it's a midwife, whether it's a physician, but the choice should be theirs. I think nurse practitioners are a very viable option for the healthcare climate right now in terms of access to care, providing people easier access to care so that I could diagnose, treat, manage illness and disease, prescribe medication, and care for the whole family.
for women of lower economic means and new immigrants, there's a huge gap for maternity care. We do recognize, for example, in maternal fetal medicine, that our main center is at the TRW building and it's on the other side of the Deerfoot, and negotiating Calgary when you don't speak English and you're new to this city and you don't have support is overwhelming. So, you know, there's definitely gaps in care.
You have to give them a reason to trust you. You have to give them your time, because those relationships take a long time to cultivate. You have to be honest, but understanding of where they're coming from. It's a different community than the community I grew up in. Things happen for different reasons. They do things differently, and that's their community you're in, and you have to be respectful of that.
If I've promised to do something for one of the First Nations women, I do try to carry through, because that community in particular has had a long history of being disappointed with promises made and not kept. So if it's as small as, you know, I'll answer your phone call in the middle of the night, to I will, if your birth happens in Red Deer, I will continue on to Red Deer with you. I have admitting closures in Red Deer. Yes, it's sometimes difficult for me to stop what I'm doing in Rocky and go with you to Red Deer, but I will do that because I don't want you to not have the person that you've established a trust with there. So we've really taken our continuity of care to a pretty high level.
Things about the midwifery model of care is that we're much more able to spend time, I think, with clients, because our appointments are longer in the prenatal period. So you actually do get a chance to dig deeper into people's lives and identify the strengths and challenges that they can bring to the situation, and start kind of bringing in extra pieces for them to fill the gaps that are going to cause more challenges for them through the course of the pregnancy and early parenting.
We have a huge population in the Northeast. Many of these women are new immigrants, refugees who do not speak English. They may not be able to drive, so they rely on public transportation. Many of them do not have family members with them who will be able to take care of their other children or be available to be support for them after delivery or even in the delivery process. I can recall a mother who basically they found a staff member in the hospital to help her in her delivery. She'd never met this woman before.
The issues with transportation in rural communities is very significant. One of the most significant factors, especially on First Nation reserves. Getting to appointments, specialist appointments, whether it's for them, whether it's for their child or a family member. If they don't get the diagnostic testing on time, then perhaps the diagnosis is delayed. Intervention could be delayed then. It is probably one of the most significant factors in terms of access to healthcare, providing the best healthcare you can get.
For my First Nations families, some of them who live on the far end of the Ochese community, it's an hour and a bit drive in. The Bighorn clientele that we work with that are out past Nordegg, it's an hour and a half drive when they're in labor. And there's no services in between. You can't stop somewhere and have a baby. You know, it's an hour and a half to even get to our small rural hospitals.
It's been hugely gratifying as a midwife to be able to start connecting those people with community resources and other women, and kind of help them find their own strength and make sure that they don't fall through the cracks.
Pregnant people who are placing their babies for adoption are vulnerable, and adoption is often misunderstood. In this segment, you'll hear about the types of adoption and the adoption process.
There's international adoption, and that means couples who reside here in Alberta and choose to adopt a child from another country. Then there is domestic adoption, which means couples who are looking to form their family through adoption come through a licensed agency in Alberta. And then there is private adoption. Somebody knows somebody who is experiencing unplanned pregnancy and wanting to place that child for adoption, or an extended family member, or step-parent adoption. Open adoption, although practiced in many other cultures, came to be a common practice today. And what that means is that there is an exchange of information. Birth parents are able to choose the adoptive parents and have some form of ongoing contact. Now, every adoption is unique, and that level of relationship or contact is different for everybody. So when somebody is facing unplanned pregnancy, the first thing nowadays is they will Google. They'll read information about what the process is, and then they'll reach out to us, usually by text message nowadays or email, sometimes still by phone call, and just make that first contact, which is very, very scary to say, I'm thinking about adoption. I've just found out I'm pregnant. I don't know what to do. Our social workers at our agency believe in providing all options, and adoption is not for everybody, and just talk about their current situation, offer support, and provide them with options and resources for those options. So if they decide to parent, we can connect them with the appropriate community resources. If they do decide to continue considering making an adoption plan, then we do a lot of counseling and support around what grief and loss is, what the adoption process is. Take a complete social and medical history, which is important. Talk about the type of family that they would hope for their child, what their heart's desire is for this child. And then they can start looking at files of our prospective adoptive parents and choose the prospective adoptive parents. Then we would share their home study, and that's a very thorough home assessment report that a social worker has completed on the couple. And from there, if they still are drawn to that couple, we would set up what's called a match meeting. That meeting is scary. I say it's almost like a very strange blind date, because everybody's excited and hopeful, but also worried about being rejected, not being good enough. And that comes from both sides, the prospective adoptive parents and the birth parent. If everybody feels good after that meeting, then we start planning for the birth of the baby and the future relationship. But we do believe that a birth mother cannot say goodbye until she's formally said hello. And so we encourage a birth mother to spend whatever time she does have in the hospital with her baby, to breastfeed that baby if she would like to do that. And if she chooses not to, then that's to be respected as well. Sometimes the hospital stay is so short that the birth mother needs to go home with that baby and spend more time. And so we do have birth mothers who ask for that, and we encourage that, whatever they need. Once the consent is signed and baby and birth mother are discharged, then we encourage birth parents and adoptive parents to do some kind of entrustment ceremony. And ceremony is sort of a big word because it can be very, very casual. Other people do a formal ceremony service. After placement, for birth parents, they can access counseling through the agency for as long as they need, as well as we have a birth parent support group that meets on a regular basis. Birth fathers are obviously very important, and they are considered equal guardians. We always try to inform the birth father whenever they're named and try to include them in counseling, education, support to help them be involved in the process. But there are all different situations, and oftentimes we don't know who the birth father is. When a birth father is involved, it's amazing and wonderful. Birth grandparents also play an important role because they are absolutely affected by this decision. So if they are aware and involved, then we also include them in counseling and support, and especially in open adoption, because the birth grandparents can still be grandparents. You know, I don't think a child could have too many grandparents to love them and spoil them. One of the biggest that I still hear, 30 years later, is that a birth mother who gives their child away, and of course we like to use the word place and not give away, is that she does not love her child. That's completely untrue. A birth mother could not make this decision without love. It is a very, very hard, selfless decision to make. I know adoptive parents still hear the terms, that's not your real child, or you can't possibly love a child through adoption unconditionally. Well, that's absolutely not true. We know that love and bond can be formed very easily and beautifully and succinctly, and is unconditional between a parent and a child. A real parent is the parent that takes care of that child. Anyone facing an unplanned pregnancy is receiving support and care and information about all of her options so she can make the best decision for her child and herself and feel good about that decision, even though it will be hard, but feel good about her decision.
Whether living in a rural, remote, or Indigenous community, or whether they are marginalized or vulnerable, each and every pregnant person should have equitable access to good maternity care. Our guests today remind us that we still have a ways to go to support all pregnant people in accessing maternity care as they journey on the transformation to parenthood. Thank you for joining us.
Thank you.